Thank you for joining us today. I'm very excited to kick off this new CHA Lunch and Learn series with what I think is a hot topic on breakthrough infections and boosters, COVID booster vaccination. So I am going to share my screen. I'll have a short slide presentation, and then we'll open it up for questions. So before we start, it's important that we understand how a breakthrough, or what is a breakthrough infection. So a breakthrough infection is an infection that occurs in a patient who is fully vaccinated. And the way we define fully vaccinated is an individual who is 2 weeks beyond an mRNA vaccine, that's the 2-dose vaccine, or 2 weeks beyond the J&J vaccine. That's the vaccine where you get one vaccination and you're considered immune 2 weeks later. So if you get an infection, a COVID infection, beyond that last indicated dose, then you would be considered to have a breakthrough infection. And breakthrough infections have been in the news. They garner a lot of sensationalism. But it's important to know that they remain extremely rare. We do know, however, that if you do have a breakthrough infection, that you are able to transmit the infection onto a close contact. And so it's important, to recognize that. And even if you have been vaccinated and develop some type of symptoms that are unusual for you, to consider the possibility of a breakthrough infection. We know that when individuals have breakthrough infections, they tend to be milder. They tend to not have full-blown symptoms. So anything unusual, it's worth a conversation with your primary care provider. And it's important to emphasize that despite all the sensationalism around breakthrough infections, the COVID-19 vaccines remain very effective in preventing most infections, and in certainly preventing severe infections that require hospitalizations. And there's more and more data showing that breakthrough infections are generally very mild. In fact, we know in the state of Massachusetts, as of a couple days ago, less than 1% of all the COVID infections right now are due to a breakthrough infection. It's actually 0.87%. And we also know that only 3 out of 100 hospitalized patients with COVID are breakthrough infections. And that only 6 out of 1,000 individuals who unfortunately die from COVID have been previously vaccinated. So these are extremely rare. And it's important to recognize that no vaccine is 100% effective. And as we continue to vaccinate the population, we will hear more and more about breakthrough infections. But keep in mind that breakthrough infections, by and large, are much milder. And to drive that point home a little bit more, and to emphasize that it's really the unvaccinated individuals that are driving this pandemic. We know that the risk of infection from COVID is 8 times greater in an individual who was not vaccinated. But the risk of hospitalization and death is far greater, 25 times greater than a vaccinated individual. This is a couple graphics from CDC demonstrating that right now in the US, and this is true for our own state of Massachusetts, almost all the strains of COVID are due to the much more contagious Delta variant. And it's the Delta variant that has really been a problem for the US this summer and caused a lot of disease and a lot of death in the Sunbelt states. We know that the Delta variant is more than 2 times more contagious than the prior variants. So on average, with the prior variants, 1 infected individual was passing the infection on to 2 other close contacts, where with Delta, we know that an infected individual can pass it on to 4 to 5 individuals that they have had close contact with. So it's clear that Delta is different than the prior strains that were circulating. We know that there's a lower amount of genetic material in samples taken from fully vaccinated patients with the Delta variant. But we also know that these individuals that have been fully vaccinated and do have a breakthrough infection, although they do have similar amounts of viral genetic material detected, they clear that material quicker than unvaccinated people. So the genetic material goes down faster in fully vaccinated people. And the important point here, it's making them less contagious for a shorter period of time. So they are, even though they are contagious, it's a much narrower time frame that they are contagious for. And you may have heard in the news in July, the report originating out of Provincetown, Massachusetts, which really was a red flag for a lot of public health officials, because this was an outbreak in Provincetown following the 4th of July holiday weekend, where there were 469 COVID cases identified. And among this group, nearly 3/4 had been vaccinated, in fact, fully vaccinated. And further investigation into that outbreak identified that almost all the infections were due to the Delta variant. Fortunately, hospitalization was very rare. Just over 1% of those infected individuals required hospitalization, and fortunately, there were no deaths. But this was a rude awakening for public health officials. And shortly thereafter, the CDC came out and issued a mask recommendation, regardless of your vaccination status, for all indoor settings where there was high or substantial transmission. And that persists today in many towns and in many states, because the COVID transmission rate is still high. And this really was the springboard for the booster conversation. And that's when boosters started to hit the media. And that's why over the past 6 weeks, there's been a lot of information coming out around boosters. I do want to point out, despite all this conversation around breakthrough and boosters, a very large study did come out of the United Kingdom. And I want to draw your attention to this red box here. And this shows the efficacy of the Pfizer vaccine. I don't have data on Moderna because they don't use the Moderna vaccine in the UK. But in the UK, they use the Pfizer vaccine. That's this BNT162b2. And we see only a very minor decrease in vaccine efficacy with Delta, that's this area shown in purple, compared to the prior circulating strains. So although there was a minor decrease in efficacy of the Pfizer vaccine, it was still pretty darn good. Now, I do want to point out, though, if you only had one vaccine, one Pfizer vaccine, the vaccine efficacy with Delta in the UK was around 40%. So it's important, if you get an mRNA vaccine, to make sure you get that second vaccine to really have the most benefit. Mid-August, let's fast track now to what the Advisory Committee on Immunization Practices was discussing at the time. They were discussing a very vulnerable patient population, or immunocompromised patients that were having breakthrough infections, because these are people that were not responding adequately to the vaccine. And we were seeing this in a host of different immunocompromised populations. Probably the groups that have been most impacted are those with hematologic malignancies demonstrated in these blue dots here, showing that these patients were not really responding to the vaccines. Half of them were not producing antibodies to the vaccines. And if we look at our organ transplant patient populations, very similarly, they were not responding to the vaccines. And we look at groups of patients that are on immunosuppressive therapies or on hemodialysis. Similarly, we saw this not, we saw a decline in their ability to produce antibodies. And that's why they were the first group to receive authorization for a third dose of an mRNA vaccine. So these individuals can get either a Pfizer dose or a Moderna dose 4 weeks after their second dose, because they were clearly at great risk for infection because they just were not responding well. Then there was more information emerging, and this was a report in MMWR showing that our nursing home populations were also having a decline in their protection from the vaccines with the emergence of the Delta variant. So before Delta was present in the pre-Delta period, in this vulnerable population of nursing home residents, vaccine efficacy was 75%. After Delta came onto the scene this past summer, the vaccine efficacy in this group declined to 53%. So it's not a surprise that this older population is now authorized to receive a booster dose of Pfizer, if that's what they originally received. And then we were seeing information coming out about our healthcare workers. This was identifying infection, not necessarily this is not necessarily symptomatic disease. This was a study whereby healthcare workers were routinely being tested on a regular basis. So it picks up infection, and some of these could have been asymptomatic infection. And we could see a gradual decline in vaccine effectiveness as the period of time healthcare workers were going beyond their second dose of an mRNA vaccine. And if we look at the pre-Delta time frame, we see that vaccine effectiveness was above 90%. And then when we look at the Delta period, that's this summer, we see in our healthcare worker population that on average, vaccine efficacy was in the high 60% range, with a large range in variability. So that's why it was the healthcare workers who have also been authorized to receive a vaccine booster. And if we look at other studies looking at vaccine effectiveness, and this was data that was presented this late August at the Advisory Committee on Immunization Practices, we see several studies looking at declining efficacy against infection. And if you overlay this with Delta, when Delta was very prevalent in the US, 94% of all infections were due to Delta, you see that the vaccine effectiveness has declined. Now, it's also important to recognize that a lot was going on this summer. It wasn't just time out from our second vaccine, but people were tired of the pandemic. They were letting their guard down. A lot of states ended mask mandates. Physical distancing was no longer practiced. People were congregating at ball games without masks, and so forth. So there's a lot of confounding factors that have contributed to the summer surge. It's not just declining vaccine efficacy. These vaccines remain extremely effective against severe disease and hospitalization. And that's what's demonstrated here. Although there was infection occurring, we see that in these studies demonstrated fairly good effectiveness against hospitalization in these studies that were depicted on this slide. So I want to emphasize that although we're talking about breakthrough infections and declining vaccine effectiveness, that is not the take-home message here. The take-home message is these vaccines are very effective. And what we're discussing around boosters should not minimize how effective these vaccines actually are and how much the disease and hospitalization and death they have prevented. This is data from Israel, and I think that the Israeli data is really what drove the decision around healthcare worker boosters. This data shows that regardless of what age we're talking about, young adults, middle-aged adults, or older adults. As we increase time from our second dose, we are seeing that immunity is waning. So the darker bar here is individuals who are 6 months out from their second dose. These white bars here are healthcare workers. So by and large, they're more than 6 months out from their second dose. And that's where we are seeing more confirmed infections as immunity is waning. And it was this information, I think, that really authorized the approval for healthcare workers to receive a booster dose. Then I want to show some really, what I think is exciting data. In Israel, after they were starting to see these breakthrough infections, they rolled out booster dosing. And initially it was for individuals 60 years of age and older. And just 2 weeks later, they saw a marked decline in new daily cases following the booster dose. And similarly, 2 weeks after rolling out this booster program, they saw a marked decline in severe disease. And largely what's driving the disease in Israel, like everywhere else in this world, is in unvaccinated individuals. So that brings us to the recently authorized booster dosing in the US for the Pfizer vaccine. The groups that are authorized to receive a booster dose 6 months after their second Pfizer dose are those individuals that are at higher risk by virtue of their age. So all people 65 years of age and older, because they're at a higher risk for more severe disease. And this was among the first group of people that were vaccinated. So we know that waning vaccine effectiveness is playing a role. Also, all long-term care facility residents are authorized to receive a Pfizer dose, because we also know that congregate living is associated with an increased risk for infection and disease. And then all individuals 18 years of age and older who have an underlying medical condition. And there are a lot of medical conditions that qualify. But just to give you a few examples: cancer, diabetes, pregnancy, lung disease, heart disease, obesity, smoking, even former smoking. So a lot of individuals who receive the Pfizer vaccine will qualify for a booster because of their increased risk for more severe disease. And then occupation. So I showed you data on healthcare workers, but the EUA also applies to many essential workers and school staff, teachers. All school staff qualify for a booster because of their increased risk and the need to maintain an essential workforce and the desire to keep kids in school. And I know for those that have received the Moderna vaccine and the J&J vaccine, you're eagerly awaiting updates on what you should do. Stay tuned. That will be coming this month. The FDA is meeting in mid-October to decide on booster dosing for both Moderna and J&J. So the take-home points that I really do want to make is COVID vaccination. We all need to do everything we possibly can to encourage our loved ones, our family, our friends, our neighbors to get vaccinated if they haven't been vaccinated at all, because that's really going to get us out of this pandemic. So that's my first message. My second message is that we want to avoid a twin-demic. What do I mean when I say twin-demic? We want to avoid both COVID and influenza this respiratory tract season. We know people are not wearing masks, they're socializing again, and so flu will be with us this winter, as will other viral respiratory infections. So you need to protect yourself against influenza. So don't forget to get your influenza vaccine. Both the COVID vaccine and the influenza vaccine can be administered the same visit. That's perfectly fine. You do not have to separate those visits. So I would encourage you to make sure you get your flu vaccine as well. So with that, I'm going to stop so we have ample time for questions and conversation. Thanks for your attention.
Okay, I have some questions in the chat. For long-term immunity, what is the best time to get a booster? And how long should we wait from the second Pfizer? I think you've probably covered this, but maybe I do not want any level of COVID, even mild, because I do not want to lose smell or taste. If I got Pfizer for the first 2 shots, would I be better off getting Moderna for the 3rd dose, since Moderna seems to be holding up better against Delta? For that matter, would a J&J dose be the best, since it is a different platform and might boost overall immunity?
Lots of great questions there. Maybe I should address a couple of them before you go on, Roberta, just so I don't lose track.
Okay.
So anybody who's interested in getting a booster dose that qualifies based on the criteria I discussed, you can go as early as 6 months after your 2nd dose. And I think it's an individual decision depending on your individual risk. If you are 100% risk adverse, go get it as soon as you can. If you are an individual that's working remotely, has very limited risks based on your lifestyle, then I don't think you need to rush out and get it. So it really is just like the initial series, it's a personal decision. It's much, much more important to make sure that if you're not vaccinated, to really get to the point where you feel comfortable getting vaccinated. That is really the most important thing. And in terms of mixing and matching vaccines, so the CDC is really recommending individuals stick with the same vaccine that they originally received. There are a number of studies going on currently looking at mixing vaccines to help enhance immunity. And there's some preliminary evidence to suggest that might help, but we don't have a lot of safety data yet on the mixing of different vaccines. And it's for that reason that CDC has been encouraging individuals to stick with what they originally received. More information will be coming out about this, and there may be recommendations in the near future to actually do this, but we don't have enough data right now to recommend it.
Will CHA ever offer antibody tests? Let's see.
So there are antibody tests available, and we do have antibody tests available at CHA, but the interpretation of an antibody test has to be done with extreme knowledge and care, because different tests measure different things. And I've seen many people misinterpret the results. We also do not know the level at which somebody's antibody correlates with protection. So there's a lot of education that needs to go into counseling people around antibodies. And it's just not so straightforward. It's not like you're positive, you're negative, you're protected, you're not. It's not that simple. So antibody tests is a complicated conversation. We probably could do a whole presentation on antibody tests, which would probably bore most of you, but they are not recommended by and large for any individual right now, according to public health guidance.
Let's see, could getting a booster now soon make us ineligible to get a better, more targeted booster down the line? Is it better to get our shots in the morning for maximized efficacy? I'm a late sleeper, so I'm thinking not in my case, but I'm wondering.
So in terms of future vaccines, yeah, there's a lot of research going on looking at future vaccines, whether they'll eventually be approved. It's hard to know. We do know that a booster actually expands your immune system's repertoire to recognize variants. So the feeling is that you're not going to need a different vaccine to be ready to respond to a new variant should it emerge. But, this is an area where there's a lot of active research, and we'll just have to keep our finger on the pulse of those results and safety data as well. In terms of timing your booster, I would suggest, because of the reactogenicity of a booster dose is very similar to the second shot that you received, and many individuals, by and large, about 70%, will develop something that's uncomfortable. You might develop fatigue, headaches, fever, myalgias, arthralgias, and you may need to miss work. So my suggestion would be to get your booster dose a day before you can stay home, or have a low-key day, not a critical presentation or not a very important day in your life. I would not get the booster dose a day before that, and I would be somewhat strategic about scheduling your booster dose.
Is fatigue / overwork of the immune system something to worry about with boosters and or getting both COVID vaccine and the flu vaccine? Would it influence timing between the second shot and booster, or between the flu shot and booster? I think you've already addressed that.
Yeah, there's really no evidence to suggest that our immune system does not respond if you give 2 doses on the same day. Look at pediatrics. We give our kids many doses of many different vaccines on the same visit. So we know that you can do that, and the immune system is very pliable and can respond to different antigens. So I don't think, based on everything we know right now, I don't think there's any reason to not do that. It's going to be more convenient to get 2 vaccines at once. For individuals who prefer to separate them, you certainly can do that as well.
How long after the booster does full immunity take effect?
Well, you still have darn good immunity based on your first 2 mRNA doses. So what will happen in about 2 weeks after your booster shot, you will enhance your circulating antibodies. So it's pretty quick.
Do they test what variant you have when you have a breakthrough case? Let's see.
So
or get COVID. And is there data? Oh, I'm sorry.
Yeah, I'll respond. So they are not testing all breakthrough infections. Early on, when we were starting to see breakthrough infections, the state was interested in testing those individuals who were hospitalized, but it's quite evident now, based on a lot of sequencing throughout the country by public health labs and by hospitals and universities, that essentially 99% of all infections are Delta. They are still doing sequencing, looking for new variants. And fortunately, we are not seeing any new variants emerge in the US. There was some concern about a variant called Mu, but we're not seeing it here. And that's why, again, it's really important to make sure we vaccinate all the unvaccinated to prevent that opportunity for more serious, more contagious variants from emerging.
Is there data to show the difference in cases after being fully vaccinated from Moderna, J&J, and Pfizer in breakthrough cases?
There is a little bit of data, you may have seen this in the media, suggesting that Moderna might be a little bit better than Pfizer in preventing infections following vaccination. But if you look at the statistics of those studies, there's a lot of overlap. The confidence intervals overlap. So it's not completely clear, but some people look at that and say, I want a Moderna vaccine. Keep in mind that when you got the Moderna vaccine, the antigen load in that vaccine was higher than the antigen load in the Pfizer vaccine. So it may just be that there was more antigen in the Moderna giving a little bit better protection. So there may be dosing adjustments made in the future. I think it's safe to say that any vaccine that we have available to us in the US is a very good vaccine and very safe and far better than getting COVID or long COVID. And you know, it helps keep your family safe and your friends safe. So, you know, as you can tell, I'm a real advocate of vaccination. And if we could just convince all our friends to be confident in getting a vaccine, we will return to a more normal life.
When we get the Moderna booster shot, when available, will it be a full dose or a half dose?
Yeah, they are talking about a lower dose of the Moderna vaccine, and those discussions will be happening in a couple weeks. So that might help avert some of the reactogenicity. We do know that patients who had the Moderna vaccine, anecdotally, we seem to have seen more reactogenicity with the Moderna vaccine, and it makes sense. There's more antigen in it.
For those who received J&J at least 6 months ago with a CDC identified condition, is it possible to get a Pfizer booster? Are there any reasons not to?
So it's not recommended, and vaccine centers have not been given the green light to do that. Having said that, I know that there's plenty of people that have circumvented the recommendations and that have taken it upon themselves to mix and match vaccines. So, you know, if somebody really wanted to do that, they could do that. Keep in mind, if you do not follow the public health guidance, if you have a bad vaccine reaction, you know, there's a national insurance program to protect people from bad reactions to vaccines with compensation. You will not be eligible for compensation if you don't follow the public health recommendations. So just be aware of that. But there's plenty of people who have circumvented the recommendations.
Roberta, before we go to the next question, I just want to check in that a time check. It is 12:35, and I just wanted to make sure that to let people know that we will continue answering as many questions as we can, probably for the next 15 minutes or so. I just want to make sure everybody's okay with that.
So shall I continue with the questions? Yes?
Yeah.
I know 5 people that have gotten breakthrough infections. 4 out of 5 ended up in the hospital. Only, hold on 1 second. Oh, I'm sorry. Only, I keep losing that, and only in their 40s. One who was in his early 60s died after 6 weeks in the hospital. He did have cancer in the past. And sorry. Lexi, can you help me with this? Oh, wait a minute.
Yeah, well, I could just comment that, you know, breakthrough infections are happening, but it's the rare situation. And certainly individuals that have comorbidities or that are older that do have a breakthrough infection are going to be at greater risk. So, you know, I don't think I'm surprised by that. Certainly if somebody's immunocompromised and they did not respond to the vaccine, you know, it's not unusual for them to have a more severe course and to end up hospitalized or be at greater risk to succumb. And, you know, that's why the immunocompromised individuals and the older individuals and people with comorbidity are now able to get a booster because we recognize they are at greater risk.
All right. If I could just finish, she went on to say that all were fully vaccinated, all were musicians. She got the 67, but got the Moderna, not able to get the booster. Why? And when will I be eligible?
So I expect the Moderna recipients will likely be authorized after the FDA and ACIP meet this month. So couple more weeks, I think you'll get a lot more information. And I expect that you too will be eligible for a booster.
Okay. How does the monoclonal antibodies infusion boost a time frame?
I meant to say affect the booster time frame.
Yes, good question. So it's going to be similar to the recommendation around vaccination to wait 90 days before you receive a booster.
For those with J&J who want the mRNA booster, should they get the full 2-dose regimen or only 1 dose?
Another great question. That has not been studied. So I really can't comment on that. And again, like I mentioned earlier, it's not recommended right at this point in time that you mix vaccines. So I can't comment what the recommendation would be.
In addition, I'm a musician and exposed to people in clubs. I'm 67, but got Moderna, if we address this. And supposedly I can't get it. So, well,
Yeah.
I think you do.
Soon, stay tuned. I think you'll be eligible soon.
I feel my volunteer work and occupation puts me at risk, and although I'm 61, and receive both Pfizer doses, I serve a membership. Sorry. Hold on. A membership association of low-income workers.
Maybe what we
Yeah.
can do is go on to the
Puts me
next
at risk.
question, Luann, and ask when will we reach herd immunity?
So there's a real controversy around whether we will ever reach herd immunity. And so, you know, if you hear the epidemiologists discuss this topic, there's no consensus. And I think people that have addressed this in the past are starting to think that we will not reach herd immunity because there's just too much disease right now and too many variants potentially emerging. So, you know, there was optimism in the beginning of this pandemic that 75%, 80% vaccination would get us there. And even in areas where we have reached that, we are still seeing cases. So I think the whole question around herd immunity is just not going to be something we can answer right now.
Now, we do have to be sensitive of time, and we do have some more questions in the chat, but Dr. Bruno-Murtha, I want to be sensitive of your time. So do you need to leave? I know that you had a meeting that you have to get to.
I could give a couple more minutes. So
Okay.
Happy to take a couple more questions.
Okay. I had COVID and was very sick, almost hospitalized after fully vaccinated. I did receive monoclonal antibodies. Is it safer to fly in the next 90 days?
So I guess my question is, how long ago did you receive the monoclonal antibodies? It really depends on the timing. They wane. They're around for 90 days. We don't have great studies to show whether the protection is good, but that's the current thinking. You're considered relatively immune to reinfection within the first 90 days of infection. So, again, it's something that I would suggest you speak with your primary care provider about, because there's not, every individual has their own risks that need to be weighed.
I've had 2 vaccine doses and Pfizer booster. Why do I need to wear a mask?
It's because we know that the vaccines are not 100% and you could still get infected. And so wearing a mask is preventing, should you have a breakthrough infection, preventing you from infecting others. And that's the reason for it.
Do biologics such as Humira and Remicade count as immunosuppressants for the purposes of these guidelines?
Yes, they do.
Let's see, sorry if you mentioned this. The Israel study chart showed a small increase in vaccine efficacy at the last month recorded. Could it be because people started to wear masks and other safety practices?
So I'm not sure I follow the line of questioning completely, but we do know that masks work. There's no question that masks work in preventing transmission of infection. And we know that vaccines work, but nothing is 100%. So that's why we have a layered approach. You know, we're promoting vaccination and we're promoting mask use to enhance our protection.
Thank you. This was very informative. And I guess that's it. Well, thank you so much, Dr. Bruno-Murtha. We wealth of information, and as we stated, ever changing, right? This was our first Lunch and Learn series. Our next one, we're going to be doing this on the first Wednesday of every month. And our next one will be on vitamin D and the importance of vitamin D and the benefits of vitamin D. So thank you all for joining us. Thank you to the Salutis Vita community, if anyone joined us from there. And we'll hope to see you next month.